Now, if you remember in the dog, when we talked about this tube that was running through the embryo and the connecting peritoneum that suspended it from the dorsal body wall of that abdominal cavity, the area of the duodenum was here. The cranial, descending and ascending portions are all this right here. You could move them around a little bit in that dog abdomen, but not too far, because that mesoduodenum had them anchored pretty closely to the body wall. And then as you dropped into the jejunum here, and then finally up into the ileum, that mesentery was extremely long, and so this was extremely mobile, and this is where we had that twisting around our craniomesenteric artery. So jejunum moved around the abdomen all over the place. You could really manipulate it a lot more than you could the duodenum. You really can't pick the duodenum out the body cavity as easy as you can this jejunum. Once we got back over to the cecum, right there, it was anchored again close to the body wall again, and into the colons, it went ascending, transverse, and descending colons right there. And again, slightly movable, but nothing like this jejunum was. Okay, we're going to have the same setup in the horse, but it looks a lot different. In this diagram here are all of our segments of the duodenum, right through here. Then we get into the jejunum, once more freely mobile. Ileum, the last little part here, coming to the base of the cecum. So on the cecum here, this is cecum, base, body, and apex. The base is anchored to the dorsal body wall very tightly. The apex is free. It's down here, so I could grab this apex and I can swing this around. I can't move the base anywhere, but this apex can move around. Of course, the body would go with it. So this point farthest from that connecting peritoneum attachment is the most mobile portion of this cecum. Just like this jejunum that's farthest away from the dorsal body wall would be the freest portion of jejunum. So part of the cecum does not move. Part of it is very free to move around. Then we get into these dorsal and ventral colons, which was the ascending colon, the analogous to the ascending colon of the dog. So that's this stuff right here. So that's ascending, so I'm going to go ahead and shortcut it. Here's our transverse colon right here. I'll come back to the ascending. There's transverse there, anchored tightly to the dorsal body wall, just like it was in the dog, but this ascending is doing a different thing. This part right down here, more mobile than this jejunum is, because we've got a longer connecting peritoneum to it right there. That point is your pelvic flexure. That point is the pelvic flexure. So out of the base of the cecum, we entered the right ventral colon. From the right ventral, it went through that sternal flexure and into the left ventral colon. So there are your ventral colons there. That's the initial portion of your ascending colon. It starts off on the right, ends off on the left. Pelvic flexure. Then we have left dorsal, the diaphragmatic flexure, and then the right dorsal was there. So this is the pelvic flexure. That is the most mobile portion of the equine GI tract. It can swing around all over the place, and you'll get to see this in lab. Come to the transverse colon, attached tightly to the dorsal body wall, and then we get into the descending colon. This is all DC, DC, DC here. Once again, just like we had over here with ascending colon, we get a longer mesocolon, so this segment of intestine is free to move around again, about the same as the jejunum was allowed to. And then when we get over here to the rectum, it will be tied down once again. So 3 highly mobile sections of the equine GI tract. Apex is mobile as well, if you want to count that as a 4th one. So because this is so mobile, this is what allows us to, when you're rectally palpating and you run your hand in through the back of the animal and into this, if you're trying to do it in the duodenum if it were open at this end, and you put your hand in here, you can't move your hand around very much inside the abdominal cavity because you have a short connecting peritoneum. You have a long connecting peritoneum here, so if your arm is in here like so, and you've got your hand down here, there's your 5 fingers, you are now in a portion that you can swing all over and start feeling the rest of these organs, because all this is going to be piled up on itself, and I'll show you that here in a second. So this long mesocolon on our descending colon is what allows us to rectally palpate horses. Something else I want to bring up here, this ascending colon right here, this is also called the large colon. And the descending colon here, they will call the small colon. So you'll probably hear your equine practitioners calling this small colon and then all this large colon. Somebody's going to say, well, Dr. Reed, what about the transverse colon? Transverse colon is stuck in place just like in the dog. If you look at this picture here, remember the dog, our caudal-duodenal flexure went behind the cranial-mesenteric artery. Transverse colon here goes cranial to the cranial-mesenteric artery. So those 2 points are still the same as they were in the dog. This transverse colon is so far forward that you really can't palpate it. Okay, it's not palpable. Second point is, it's not going anywhere. It's tied down tight. This is what's going to cause you most of the problems right here. This is going to it can sit there and twist on itself in a spiral. It can get flipped up over the gastrosplenic ligaments, rhinosplenic ligaments, all types of things like that. It's going to get tied up, and you've got to get in there and hopefully rectally manipulate this back into a normal position. If not, you got to do it surgically. Jejunum and the horse, this jejunum can actually get caught up in your epiploic foramen. So we'll be able to see that spot in the horse as well. Doesn't happen in the dog for the most part, but is common in the horse. So transverse colon, it's not going anywhere. You can't touch it. And so it's just, I guess, the no colon, small colon, large colon, no colon. I don't know. It's not included. So this is how this is going to work in the suspension. So how is all this packed into the horse? Okay, here's our cecum, base of the cecum here, body apex coming down. Here are our ventral colons, pelvic flexure, dorsal colons here, and up to the transverse colon. Okay, how does this sit in the horse? We're looking at this dorsally. So what happens is the base of the cecum will sit up in a dorsal position, and the apex will point towards the front of the horse in a cranial direction, and this tip of this apex will sit on the last sternobra, right on that xiphoid process. Right ventral colon comes down. We're going to bend this up. Keep breaking my skinny part of this. The ventral colons will wrap on either side of that apex like so. So the apex is sitting right here behind the sternal flexure. So base of cecum, right ventral colon, sternal flexure, left ventral colon. Pelvic flexure is this thin part here. This will turn back up on itself, and the left dorsal colon lays on top of the left ventral. Comes around as the diaphragmatic flexure to the right dorsal colon, and then I'll create one here, and our transverse colon comes across the midline. So when you look at this thing, the left dorsal colon is on top of the left ventral colon, and they're actually stuck together. You're not going to be able to get in there and put your finger between them because they're stuck together. Turn it around this direction, we see the base of the cecum here. Body comes down, apex disappears. Here's your right ventral colon and right dorsal colon, and they'll be stuck together. If you turn it upside down, you can see the apex of the cecum tucked right in behind that sternal flexure. And you may be wondering, why do they call it sternal flexure and diaphragmatic flexure? The front of the horse is now this direction, dorsal is up. The sternoflexure sits right on top of the back of the sternum. And the diaphragmatic flexure, what really happens is this falls over the front of the sternoflexure and kind of sits like this in front of it. Forget the back end of this right now. It falls over the front of it and it falls into the back of that diaphragm and pushes into the back of the diaphragm. If my hand were the diaphragm right there. So it falls over the front. So this is in contact with the diaphragm, and then this is sitting on top of the sternum back there. So that's how that thing sits. As we will see with our quadrants we're going to talk about in a moment, these are occupying the ventral parts of the abdominal cavity. This base of the cecum is going to be up in the dorsal part, and we'll have some other structures in the dorsal, sitting dorsal to this, and we'll talk about that here shortly. So that's how that's going to fit together. So this is the most mobile portion of the GI tract, and you can see that now. It's anchored here at the base of the cecum and over here at the transverse colon, but this double loop here is free to move all over the place. It can twist on itself like that. It can twist back this way. It can get up over things. It can come back and tuck underneath, stuff like that. So this is going to cause problems, and that's what we're going to do later on in your career here in the vet school. We're going to teach you how to fix those things. The one thing I want to mention here is when we start having colic problems in horses, if it's not a twisting torsion type problem, you can get a stoppage of flow, a mechanical stoppage where narrowings occur, or it can be a physiologic problem of movement through the GI tract. So we can get impactions along this tract in the three most common areas in order. The first one is going to be in the ilium. And that's usually a lack of motility with the muscle in that ilium. And so as all of this is coming up toward this iliac orifice, and this is going to have a real big papilla on it called the iliac papilla, very, very tight. Everything's going to back up that point right there, but it's usually a motility problem. That's your first place that you can get an impaction or a blockage in a horse. The next one is the pelvic flexure. This is due to a narrowing in the gut diameter of the lumen. So second one is there. Third one will be the transverse colon. Transverse colon, when you get to it, it's almost a triangular shape, and it's very, very short, and it's so nebulous looking. I'll never tag it. I'll show it to you, but it's really hard to kind of discern. And then the descending or small colon comes after that. It's a very cone-shaped thing, and if stuff comes in here too dry or too hard, or if you have an enterolith, it's going to get wedged in this spot here. So the three places for most common sites of impaction, number 1, number 2, number 3. This is just mechanical. Stuff is too big to get through there, get stuck. This is a physiologic one up here that ends up, I guess, in a form of mechanical. So, 3 common sites of impaction in the equine GI tract. And that's going to get us, I'll talk about the duodenal papilla in this descending duodenum when we talk about the liver. So I'll come back to that. That gets us to bands and sacculations. Okay, you got the definition right there. I won't bore you with that, but I want to show you a piece of descending or small colon in a horse. Here is a band right there. Here is another band right here. If you look down here, descending colon, number of bands, 2. There's 2. Does it have sacculations? Yes. Did the dog's small intestine or colon ever look like this? No. There are those little sacculations, also called haustra, right there. These structures are used to propel this very thick, it's almost like dry oatmeal type material ingested through this tract and helps push this stuff on through. and you can see these shapes are about the shape of little fecal balls of a horse, and they're already kind of forming up in here, and they just kind of slide from the next sacculation to the next on the way out. So there's bands and sacculations. You can see the number of bands here. They're listed. Left dorsal colon, it's going to start off with 1 and end up with 3. So that's why the 1, 3 right there. I want to point out that when you look at these bands, for instance, on that descending colon, when the peritoneum, or the mesocolon peritoneum comes down to that point there, you're going to have one band here, and the other band is kind of sitting right there in that mesocolon. Okay, they're pretty easy to see on the horse, but when you're palpating them, you're feeling them, not really seeing them. On the larger sections of intestine, the cecum and the ventral colons, these ones that have 4, when you look at that on cross section, you'll see one out here pretty well. You'll see one over here pretty well. The other 2 are pretty close together, and they're tacked down in the suspending, the mesocolon, or if you've got your dorsal and ventral colons slammed together, they're kind of crammed down in here. So you can see some of those bands easily. Some are going to be buried through here. Don't worry about finding all 4 of those, okay? Just know that they have them. You can kind of palpate in there and feel them. I'm not going to name these bands. They have designations. It's just a band, end of story, okay? So you will not have to count bands around these things on practical days, so they won't always be obvious. This one here, it's nice and pretty. This was on the anti-mesenteric side. This one over here is a little fuzzy because we had the mesocolon attaching here, but it's all ripped off, so this shows. Okay? So when you have your hand inside an animal, number of bands are different. Sacculations are different over here, so this combination will let you know what you're feeling. So if you think back to our large colon, the ventral colons, 4 bands, sacculations. The dorsal colons, not sacculated. If you are grabbing that pelvic flexure and palpating down it, and you feel sacculations on the top and no sacculations on the bottom, you have a 180 degree twist in that one way or the other. Okay, it has been twisted because the sacculations should be on the bottom, non-sacculated on top. Now you got to figure out which way it twisted. Did it twist this way or did it twist that way? And you've got to manually, with one hand, slip it back into the position that it needs to be in and hope it doesn't retwist on you. So, this is how that works out right there. There is your formula for who has what and used for identifying intestinal segments and during palpation. And you'll notice transverse colon is not on here. It would go from 3 bands down to 2, but it's not palpable. It's not going to go anywhere, so it's not on there. And finally, with the abdominal topography, when you have a horse that's come in with a colic, you will start auscultating, get your stethoscope and put it on the side of the animal and listen for gut sounds. If you're getting gut sounds and churning and gurgling through there, those things are called borborygmus. That's singular. Borborygmi is gut sounds, plural. That gut is working and it's moving. It's the absence of sounds that's the bad sign, where everything is just static, stasis, nothing's moving. So as you start listening, you're going to listen into these different quadrants on the side of your animal. And if you hear gut sounds, you'll hear sounds throughout the whole abdomen, but when they're really, really loud where you are, you know, okay, I'm hearing a sound in my cranioventral aspect on the left side. It's very loud. It's not distant somewhere else on the horse. It's right here in my stethoscope head. These 2 things are candidates for somebody making noise. Okay? This is how this works. So when you take your animal and here's my picture. Here is the right side of the horse. What you need to remember is when you are imagining these quadrants, there is a lot of abdomen underneath this rib cage. Okay, it's not just back here in the flank, so don't make your quadrants like this. Your quadrants have to be over here like so. So if you draw a quadrant here, and I'll cut this in half there and cut this in half like this. So here's my cranial dorsal, cranial ventral, caudal dorsal, caudal ventral. So if I look in this quadrant, I see the base of my cecum. The body's going down here and disappearing. I don't see my apex. There's my base. This is a kidney. He's kind of quiet, doesn't make much noise. And there is a loop of intestine right here, which is your descending duodenum. So base of cecum, descending duodenum. So right side, I hope I said right side earlier. Base of cecum, descending duodenum, caudal dorsal quadrant. There they are. Over here in the cranial dorsal, on the right side, descending duodenum. And I put liver in here just to let you know there's something up there taking up a bunch of space. It doesn't make sounds, but that's what else is up there. This descending duodenum will slip down underneath the liver here. So that's the only thing you'd hear up there. There's nothing else because the liver is kind of blocking everything out. The ventral quadrants, it's your dorsal, and here's the ventral, right dorsal. It's those segments of intestine there. The body and the apex of the cecum are down on the ventral midline, so they don't come into play right here. Over here on the left side, again, you cut this like this. Spleen is right here, not making noise, but there's our stomach, primarily the body right there. The ventral quadrants, here's my dorsal and ventral colons again, left side. Pelvic flexure is back over here. It's just really one little spot there. You would hear it over here, but this is going to make a lot more noise than one little thing right there, so we don't say pelvic flexure. When you get in this left caudodorsal quadrant, here's where all of our jejunum is. Ileum's up here as well, kind of cutting across the midline over towards the base of the cecum to enter it. But there's more jejunum than ileum, and there's more small colon than ileum. So if you look through here, I'm seeing loops of intestine here, and I don't see any bands on it. But if I look over here, I see a band right there, and I see a band right here. The saculations aren't very pronounced, but they got some little dark creases in here. So here are my loops of small colon. Here is the small intestine, the jejunum. They have the colon over the jejunum. This can be mixed and matched all over the place in here, but they're occupying this dorsal caudal quadrant left side. They're not over on the right side because the base of the cecum is over there occupying that. You may see a few pieces poking over there, but most of them are over here. So that's how those quadrants work. So if I'm hearing gut sounds up here, it's either my small colon or the jejunum when they're loudest right there. That's how that works.